challenges of having.
Good morning, good afternoon, good evening. We are so sorry for the delay, but we had some technical issues that I believe, I hope, have been resolved. We are here today with Dr. Bose, who is with MD Anderson in Houston. And we are so pleased that he's with us today. He's been such a great person to have on these webinars. He's so knowledgeable about MPNs, and today we're going to talk about polycythemia vera. And Dr. Bose, can you just give us an update on some PV clinical trials or anything that's going on in the PV world currently? And then we'll go to some questions.
Yeah, absolutely. Thank you, Anne, again for having me. It's always a real pleasure to do these. So yeah, speaking of PV news, on the drug development front, I would say the most recent news is the likely approval of rusfertide. So let's start with that. Rusfertide is a hepcidin mimetic, right? So hepcidin is a peptide hormone or protein released by the liver, which you're trying here to mimic the action of that, right? So what hepcidin does is it normally, its normal function is to reduce iron absorption from the gut and also store or sequester the iron away from the bone marrow. So the idea in PV being let's deprive the bone marrow of iron. Let's starve the bone marrow of iron. So that is what hepcidin does, and that is what this drug does. It's rusfertide given once a week under the skin, and the idea is to mimic the action of hepcidin and basically, again, deprive the marrow of iron so that you limit red blood cell production. Now, intuitively, as you would imagine, what rusfertide does best is to control that hematocrit, which we know is the #1 goal for people living with PV. So we know that always needs to be kept under 45. And so rusfertide does a beautiful job of that, of controlling it consistently under 45 and reducing or frankly eliminating in a lot of patients the need for phlebotomy.
It's fantastic.
So it is certainly very cool. The science is very, very interesting. It's a very, clever way of intervening in that whole red blood cell production cascade, by again depriving the marrow of iron. Now, another thing that was a pleasant surprise actually in the top line results that came out from the phase 3. So again, just to give a little bit of context, so this drug was being developed or is being developed by a company called Protagonist, and recently they entered into an arrangement with Takeda, and there was a press release from Takeda just a few weeks ago talking about the positive top line results from their phase 3 trial called Verify. So we haven't seen the full data set. We probably will at an upcoming meeting. But besides the hematocrit control and phlebotomy elimination that everyone expected, because we've already had the phase 2, the phase 2 results have been out in the public domain for a little bit, already published in the New England Journal. So we already know this is a great drug to do that. But then also it controls symptoms. So that is actually an interesting additional strength of the drug to me. So I think, this is probably the most recent, latest advance in the field, and everything points to likely approval based on the top line results. But I would be remiss not to mention some of the emerging data on ropeg interferon alpha 2b, also known as BESREMi, approved for PV in the US since the fall of 2021, and some data on ruxolitinib or Jakafi, which has been around for PV for over a decade now, right? So two things I want to mention. Both ropeg and rux now have proof of improving event-free survival. So this is actually a big deal, right? So if we think about it, In PV, we've always said, let's control the hematocrit, let's eliminate phlebotomy or reduce phlebotomy, let's prevent clots.
Mhm.
Clots are not the only events, right? So these patients we know, unfortunately, can progress to myelofibrosis or worse, transform to acute myeloid leukemia. So
Mhm.
in both trials, one is called MAGIC PV. That's in the second line setting in the context of ruxolitinib. This was done by Claire Harrison and colleagues in England. And then there is PROUD and Continuation PV, which was a European trial of ropeg, the BESREMi, in sort of a mixed population, hydroxyurea naive as well as hydroxyurea exposed. So both these trials, again, to come down to, kind of to cut to the chase here, both the trials showed improved event-free survival with these agents. And both these agents are able to bring down the allele burden of JAK2, which is of great interest to patients and us as a research community. If that comes down, we know JAK2 is the pretty much the exclusive driver of PV in a lot of patients. There are no
Mhm.
other mutations, it's just JAK2.
Mhm.
And we know in experimental models that if you put JAK2 mutation into a mouse, you get PV, you get the PV
Mhm.
phenotype. So if you can bring that down, which both Rux and Ropeg are able to do, we now also see that this quote unquote molecular response is correlating with that event-free survival. So I think that is another equally exciting development in PV.
Amazing. That is fantastic news. And you mentioned symptoms, and everybody sends messages to us and says, but what is anyone doing about symptoms? And we know that Rux does mitigate some of the symptoms, which is fantastic. And they, thank God for ruxolitinib. But we also know that there are still other symptoms that are not, that have not been addressed or been able to, go away or subside, with the current medications available to our patients. So this is great news, great news. And so is this drug, let me ask the first question here. So would this drug be in combination with another drug or just on its own?
So you mean rusfertide?
Yes, rusfertide.
Right. So rusfertide, that remains to be seen, frankly, because
Okay.
in the trial, they allowed patients who were not on any cytoreductive therapy and who just got rusfertide or placebo. And then there were also patients who were on cytoreductive therapy, which could be hydroxyurea, which could be interferon, which could be ruxolitinib, but was still phlebotomy dependent, right? And they allowed those patients also who could add on the rusfertide. So I think its use really will evolve once the approval is there, once we see what the language of the approval is. But at least based on the data, it could be used both alone and in combination.
Great. That is great.
Mhm.
And so, a question here is about hydroxyurea. Is that still like a go-to drug for PV patients with, like in your practice? Is that something you automatically go to, or what do you look for in, some differences perhaps in your patients? Because we know this is a very heterogeneous group of patients. Do you automatically prescribe hydroxyurea or automatically prescribe interferon? How do you approach your treatment options?
Yeah, absolutely. And it's not a very straightforward answer. And so I will say it is absolutely not my go-to. It's not my automatic go-to, because I think we are sort of past that era, maybe. And, I think now we are in a paradigm shift. We are sort of in the middle of a paradigm shift where, because of some of the data I was just alluding to, because we can lower the JAK2 allele burden now, we can hopefully achieve disease modification in PV. And that would be through ruxolitinib and ropeg. I think we're kind of witnessing a shift, where increasingly in the frontline setting, I'm talking to patients more and more about ropeg.
Mm-hmm.
because one, it's broadly approved for PV.
Mm-hmm.
So, it has the FDA's blessing there as a kind of a line agnostic and risk agnostic approval. And more importantly, we have this JAK2 lowering. It's really robust, actually, very, very profound molecular response with, I think, around 20% becoming undetectable. So 20% rate of
Fantastic.
complete molecular response.
Right.
And then, this event-free survival has been demonstrated. So I'm talking to patients more and more about that. Now, ruxolitinib, again, great drug. You alluded to the symptom benefit of it. Fantastic. I think the best thing we have for symptoms for sure. That one, I've always tended to use it in second line, which is consistent with its label.
Mm-hmm.
FDA is pretty specific about the label for
Yes.
Rux, and it is after failure of hydroxyurea.
Right.
So now I would also extrapolate that to somebody who's, say, had interferon in frontline, now that we are more and more, going to see or seeing interferon. And I think if they fail that, I think ruxolitinib is a fantastic second line drug. I haven't used it frontline. I will not say that that's wrong, but it's just not its label. It's just not how it's approved in the US or anywhere. Um, there was a study done called the
Yes.
Ruxo-Beat study, and it was
Yes.
ASH, in the last few years.
Mm-hmm.
And that one, actually, it was designed in a bit of a strange way where you had to get to a zero on your symptoms. And because of that, it actually was not a positive study, which is a bit unfortunate because you're not going to get to zero on a number of symptoms. So that I think, perhaps, at least, if you look at it superficially, kind of made it a negative study. But Rux is a great drug. But again, in my practice, it's usually a hydroxyurea or a Ropeg, in the front line, and it is usually ruxolitinib in the second line.
Okay. And this question, there's two questions here that are right. So one is, how long does it take Jakafi to become effective? And the other one is, how long does it take interferon to become effective? I know a lot of people have to adjust the doses and so on.
Yeah, yeah. So Jakafi is very quick. It's very quick because it blocks the cytokines right away by blocking JAK-STAT. It's got a short half-life. You take it twice a day. So Jakafi should be very quick. More of the experience is in myelofibrosis, although we have a lot of experience by now in PV as well. But in myelofibrosis, where the symptoms and the spleen can be more pronounced, you see a dramatic result in 4 weeks. The patient is like feeling like a new person. Spleen has shrunk quite a bit in 4 weeks. So Jakafi is pretty quick. Now, Ropeg, that's a good question. Ropeg, or any interferon for that matter, is not that fast. And I think it took a median of about 7 months in the Ropeg studies
Wow.
for it to control all the blood counts, what is called CHR, or complete
Yeah.
hematologic response, right? So Ropeg is slower acting. One has to be patient with it, like with any interferon. In fact, in those PROUD and continuation PV studies that I was alluding to, in the first year, hydroxyurea actually beat Ropeg. And it was only later that the benefit emerged after 2 years. And at years 3, 4, 5, 6, you saw the superiority clearly emerge, whereas you didn't quite see it in the first 2 years. So that tells you that Ropeg takes time. And yes, there is a dose escalation. FDA is very clear about how to do it. You go up by 50 every 2 weeks. Um, you don't have to get to 500. If you get to a complete hematologic response at a lower dose, just stay at that dose.
And so what are your thoughts about pegylated interferon versus Ropeg?
Right. So sorry about that.
I mean, they're similar, but
Uh, yeah. So Pegasus, before Ropeg, of course, that is what we had. And, we still have it. Now, Ropeg is obviously more convenient. That's an easy one, right? It's every 2 weeks instead of every
Mhm.
week. And then in the PEG Vera study, which the FDA used to approve it, after a year, a lot of patients could do once every 4 weeks. So you have that, this super long acting, as it is called, the monopegylation that they've done. It certainly makes it more convenient. Now, is it safer? Well, it may be, but we don't have head-to-head data. So you're looking at Pegasus trials and BESREMi trials and trying to sort of gauge, but it does seem to be well tolerated. It seems to have a good safety profile, and it appears that it may be better than that of Pegasus. Now, I will say, though, that there are patients who tolerate one better than the other. So that it could go either way. So a given patient could tolerate Pegasus better or Ropeg better. So yeah, Pegasus is still useful. There's been a shortage. I believe there's been a global shortage, not
Yes, there is.
affecting.
In fact, Dr. Messett, yes, he just wrote a paper about that. Yes.
Right. So that is there. But I think in the US, because BESREMi has the approval, right, it,
Mhm.
it may be easier to obtain as well, right? It's
Yes, and it was approved for MPNs, where pegylated
has never
Piscis
been
was not.
correct.
And
Correct.
so, I just told Mallory this morning that I remember meeting with Roche and Genentech when trying to get them to allow us to use Pegasus for MPNs. And
Right.
so BESREMi's been a nice, addition to
Yeah.
the treatment options available. So this question is, do you prescribe hydroxyurea to younger patients? Should we be taking it? There are a ton of younger patients, as you probably know in your practice. We, started a pediatric and young adult program here because nobody was really paying attention to the fact that there are much younger patients being diagnosed. So would you prescribe hydroxyurea given your answer to the other question that, yes, you do prescribe hydroxyurea. Do you prescribe that to younger patients?
I try not to.
Excuse me.
I try not to. Like I said, I think increasingly we as a field are moving away from hydroxyurea
Yeah,
because it's a fairly limited drug in what it can do. It certainly controls counts well, and it reduces clotting risk, but it doesn't have any effect on the disease biology, right?
right.
So more and more we are moving away from it. Younger patients, I try not to again. I'll offer them interferon or a clinical trial, given the their exact circumstances.
Yes,
And frankly, even with older patients, I make sure to have this conversation that you have hydroxyurea, which has been the standard for decades, but here's what it can do, here's what it cannot do, and you have Ropeg and Rux, which have this event-free survival
right.
benefit demonstrated and can reduce the JAK2 level, right? So I make sure to have that conversation with everyone.
Yes. Thank you. Does having PV affect your thyroid? I have fatigue and have gained weight. I've heard this a lot about the thyroid and actually thyroid cancer in some PV patients.
So actually not something I know. I mean, so
Okay.
again, just not something I've come across. You see more lymphoma in PV patients. We know that. Now for thyroid, what it makes me think of the question is that with Ropeg or any interferon, you can get some autoimmune side effects which sometimes affect the thyroid. So
Mm-hmm.
hypothyroidism due to the interferon, not due to the PV. So again, maybe it is true, but not something I've come across.
Mm-hmm. We know from many studies about fatigue that fatigue is still the #1 issue with MPN patients. And this question is obvious. Jakafi has reduced my allele burden from 65% to 25%, which is wonderful. But their main symptom is still fatigue. And what can this person do about that? I mean, that we talk about this all the time. It's so hard. And what we consider fatigue has nothing to do with the fatigue that our patients feel. It's
Right,
different. My
right,
fatigue is
right.
very different from an MPN patient.
Right, right. And it is the most vexing symptom. It's the hardest one to treat in MPNs for sure. And
Yes.
I will say that, JAK inhibitors, for all the benefits they've brought to people, are not that good for fatigue, in my view. That is where, that's a little bit of an Achilles heel for them. They are very good for itching, night sweats, bone pain, weight loss. They're great for those, not as much for fatigue, which is why I'm very intrigued by this rusfertide data on the symptoms, right?
Okay,
Because
yes.
I'm actually perhaps even a bit more excited for the symptom data than the hematocrit data, because the hematocrit we know how to control. Okay, I
Yes.
mean, if you dose your cytoreductive drug, whichever it is, if you dose it well, you'll usually control the hematocrit. But I think the symptom data, I'm really curious to see whether fatigue was affected, and if so, how much. Because you're right, and the person asking the question is right. I mean, JAK inhibitors have a limited benefit on fatigue.
And I know people on interferon who say their fatigue in some patients got even greater, like right after their injections for about a week or something like that. But yeah, I mean, this sounds very exciting if in fact, we have a new drug that can mitigate or eliminate some of this stuff. But do you have experience with patients who take hydroxyurea together with BESREMi? And how long does that period last on average before you completely switch them over to Ropeg?
So, we try not to do both, but
Okay.
then the FDA is fairly clear in their label for BESREMi that if you're on hydroxyurea when you're trying to make that transition, um, it is weeks 3 through 12 that you taper the hydroxyurea over, right? The first 2 weeks you leave it untouched, and 3 through 12 you try to taper it completely off. And I have not had a problem with that. I've always been able to do that.
Okay, that's great news. So this person, are there any considerations to be taken into account if I have PV, I've had a hysterectomy, and I'm considering other than phlebotomy to quell rising platelets and red cells, which has had a hiatus while my stomach ulcer from aspirin heals and hemoglobin levels improve? Wow. I have been relatively asymptomatic since my diagnosis in 2013 and had been until a clot in October 2004. And fatigue goes with anemia. I'm not sure what the question is here. Um,
I also wanted to be sure I understood the question clearly.
yeah, I'm not sure what it is. Yes.
Are they asking how can they control their white cells and platelets? I heard that in.
Yeah, yes. How can they, yes, reduce their platelets? I think, there's a lot of, maybe we should talk more about surgeries in PV and, whether, I'm not quite sure about this question.
Sure, sure. I'll just quickly say that if you're looking to control your white cells and platelets, rusfertide is probably not the drug you want to be looking at, because with that drug, the white cells do not go down and the platelets actually go up. So just something, because we were talking about rusfertide, just something to throw in there. But ruxolitinib, Ropeg, and even hydroxyurea, I mean, they all control the counts pretty well. I wasn't clear if the person was on
Not,
it or not on it.
yeah, and I'm not sure, but I'm looking at this and this question came up a couple weeks ago. And that is for patients that are taking aspirin every day, prescribed or recommended by their physician, um, do sometimes end up with stomach ulcers. So, I mean, there are all these other things that can happen from taking a drug that is supposed to be helping in some ways, but is that pretty common to add an aspirin to some of our protocols?
Yeah, actually, a baby aspirin, important, a baby
Yeah.
aspirin, not a full strength aspirin, actually generally should be part of everyone's treatment regimen with PV. So that is just, there was a study called the ECLAP many, many years ago showing that that really provides benefits. And it's surprising to me if that alone can cause a stomach ulcer. It shouldn't, but in general, one should take a baby aspirin. Yes, it has
Okay.
proven benefits.
This person is JAK2 positive with PV, diagnosed in 2022, so just a couple years ago, after 2 major DVTs, and was treated with hydroxyurea, Eliquis, and phlebotomy. Their MPN specialist recently mentioned that this person is transitioning to myelofibrosis and they've started Jakafi. I'm wondering if there is some way of reading the CBC results to tell whether the PV or MF are beginning to get worse. So here we go with the progression. This is definitely talking about progression and how does one know if they are progressing. And we've talked about this for years, and I know the MPN Research Foundation is finally going to, really take a chunk out of this or try to get to some place in terms of determining this. There was a study done by the Germans. We posted the paper. They talked about that paper specifically, I think at ASH the year before last, but that they did kind of find a way to, through genetic or genome sequencing, who would progress and who wouldn't. That was pretty phenomenal. But what are your thoughts on progression?
Right. So, but I would say practically, and I think that goes back to this person's question, like how can the patient tell or how can you tell from the blood work?
Mhm.
The biggest clue is that you're becoming anemic. So you're having the opposite problem, right? You had too many red blood cells, now you're going in the opposite direction. So excuse me, your hemoglobin is dropping, or you're needing less of your hydrea, let's say, or whatever you are on for your PV, you're needing less of that to maintain your hematocrit under 45. That is a clue that you're progressing towards MF, but it requires a bone marrow. It
Yes,
cannot be determined without one.
absolutely.
There are some other things like LDH going up, spleen enlarging, white cells going up, and blasts appearing in the blood. All of these are clues that PV is progressing to MF.
Mhm. What about the patient that hasn't been to their hematologist, so they haven't had, recent blood work, they're not feeling any different, or are there other symptoms that, now I know an enlarged spleen, you can't eat as much, or, you start to feel full, or, some of those things. But if I'm a new patient, or if I'm a patient that's really just living my life and not really paying attention much, but start to see some other things happening to me, what would those symptoms look like, or what would they be?
Well, you would, again, most likely somebody with known PV would be, seeing a hematologist every, 3 6
Right.
months, maybe once a year. And so you would likely pick it up from the blood work before the patient feels anything. But if, let's just say, that is not the case, they haven't had blood work in a long time, well, then it would be the typical symptoms. It would be spleen enlarging, causing the early satiety, the dragging feeling, etc. More fatigue, than before. Maybe the itching, the night sweats, the bone pain, etc. But that would not be a very reliable way of telling it's going into MF, because PV can give you symptoms as well. Worsening PV could give you those same symptoms. So
Mm-hmm.
I think this is really something that the blood work would tell you about, and then you go and have a marrow and you have confirmation or not of that.
And one question that always comes up is, how often should I have a bone marrow or biopsy?
Only as clinically indicated.
Okay.
So there is no role for routine bone marrows, at whatever interval. There's nothing like that. However, I will say again, we are talking today about a paradigm shift. As we go more in the direction of disease modification and we are starting to use drugs that can do that, there may be an interest in watching that JAK2 drop. Like let's say I'm treating somebody with interferon, and these drugs are so well known for the molecular remission. So, in discussion with the patient, again, this is not a hard and fast recommendation, but one could elect to just keep an eye on that JAK2 allele burden once a year by doing a marrow. And you can check it on the blood, but if you do a marrow, you can also see if there are any, changes in the morphology as you start to use a disease modifying agent, because that's the holy grail, right? Like, can we cure PV? But I want to stress that in routine practice, there is no indication for regular bone marrows. It's only if clinically you're worried that, hey, this may be turning into MF or worse AML, or I mean, like something is off, sure, but there's no routine guideline.
What would you recommend to females who have polycythemia vera that would like to raise a family or have children?
Yeah, so the few studies that there are actually find a very low rate of pregnancy complications. Most pregnancies do go to term, and they are healthy pregnancies. So there's just a few things to remember. The aspirin has to be there throughout pregnancy. So that is important. That needs to continue the whole time. Hydroxyurea, Jakafi, these things are not safe in pregnancy. Interferon is the only one. If the person has to be on a cytoreductive agent, because remember, these are going to be young females, they may be low risk, they may not even need a cytoreductive agent. But if they need one, it should be interferon. And what do I mean by need one? Well, if they've had a clot in the past, or they've had a pregnancy loss in the past, things that, many pregnancy losses are due to clots, right? So if you've had a pregnancy loss or a known clot, well, then your physician may want to continue cytoreductive therapy through pregnancy, which would be interferon. And then finally, there is a role for low molecular weight heparin for 6 weeks after delivery. So in the postpartum period, there's a role for that to prevent clots in MPN patients, who become pregnant. So there is that 6-week postpartum low molecular weight heparin.
Okay, thank you. Why do PV patients have night sweats and itching? What is causing this, and what can this person do about it? Currently, they are taking BESREMi.
Yeah, so night sweats and itching is probably due to cytokines. These are inflammatory mediators, inflammatory chemicals that are circulating in your bloodstream with PV or any MPN, and it's driven by this overactive JAK-STAT signaling. So the best way to shut them down is a JAK inhibitor. So itching, night sweats, I think ruxolitinib is far and away the best drug for.
So would that be in combination then with BESREMi?
Well, you could do it. I mean, ruxolitinib and interferon have been combined, not BESREMi, but people have combined with Pegasus, for example. That's not to say that you cannot. I have a patient actually on that combination, 2 patients actually. So it can be done. There's just not published data on combining ruxolitinib with BESREMi, but there's no reason it couldn't be done. And one just has to be careful about the blood counts and watch for any toxicities. But yeah, it can be done.
What is the frequency of phlebotomy? If you what do you advise for newly diagnosed patients? Are there any side effects? Sorry.
No, phlebotomy is usually pretty well tolerated. It's rare to have side effects. Now, the rare patient may feel dizzy, lightheaded, after having that volume taken out. But we don't run into that much. Now, in terms of how many or how frequently, there is no answer to this, because everyone's PV is a little bit different in terms of how proliferative it is. So you may even need it several times a week in the beginning. You've got to get it down below 45. The hematocrit has to be under 45. So whatever it takes for that.
Is hydroxyurea better than phlebotomy to control platelets, hematocrit, and iron?
To control platelets, hematocrit, and white cells. Yes, not sure what's meant by iron in that question, but yes, it is definitely better than phlebotomy. Dr. Barbui has shown this. It's not a head-to-head trial, but he went back and looked at hundreds of patients, and came up with a robust sort of like those matched analyses where you try and match patients in the absence of a prospective clinical trial. You try to do your best with matching patients. And there is such an analysis published in 2017. I was actually looking at this recently for something where hydroxyurea was shown to be better than phlebotomy. So yes, it absolutely is.
Mm-hmm.
Something is better than nothing for sure in controlling the blood counts. And regarding the iron, I'm not sure if this is what was being asked, but maybe they were asking, can it make the iron status better? And the answer is yes, because if you rely on phlebotomy, you're going to drain all your iron. You're going to become very iron depleted. So yes, in that sense, yes.
What is the estimated percentage of those who convert from ET to PV?
Oh, I don't know the percent. I've not seen that, but that is actually, it happens. That's, ET is, they're all on the same spectrum, at least as I see it. And ET can turn into PV, not usually the reverse, but
Mm-hmm.
ET can turn into PV as the JAK2 allele burden increases. So as that increases over time, that can happen. But yeah, it's still, in my impression, fairly uncommon, and I don't have a percentage for it.
Okay. How can you get your lab to assess your mutations? So how could a patient get that information?
So generally, it's NGS or next generation sequencing. You can also have digital droplet PCR if you are just looking for the JAK2. So what is typical is today, you'll get an NGS panel. You'll get a myeloid mutation panel with any number of genes. Ours has 81, but there are, commercial ones, and other institutions have their own panels. And they employ NGS, next generation sequencing. And it's not just one gene, but a whole range of genes. But then over time, so let's say you have JAK2 because 99% of PV have JAK2 as
Mm-hmm.
their driver. So let's say you know that, and you're now just trying to measure the amount, or technically we call it the variant allele frequency or allele burden, but basically it's the proportion of cells in your bone marrow or blood that have the mutation. For that, you probably don't need NGS. You could do, specifically for JAK2, the digital droplet PCR.
And is there any correlation between taking hydroxyurea and hair loss for women over 60?
I think yes. I
Yeah.
think yes. I don't think it is a very profound effect, but I
Mm-hmm.
think it is there. Just from what patients have told me.
Yeah, I think so too. So Dr. Fleischman in California did a study on inflammation, and you did mention that earlier. And we've had patients talk to us about taking anti-inflammatories, eating anti-inflammatory meals, and trying to maintain their health in different ways. Can you speak to the inflammation piece? And are you aware of any other studies that are showing some progress and some hope?
Sure. So to some extent, for sure. So, inflammation is absolutely integral to MPNs. So all the MPNs are inflammatory diseases driven by the mutated clone, right? So there is a mutated clone, as you know, JAK2, MPL, CALR, and they are leading to this inflammatory milieu. And actually, you mentioned Dr. Fleischman. A number of years ago, she had actually elegantly shown that it's a self-reinforcing environment where the mutated clone leads to the inflammation, and then the inflammatory markers or mediators actually allow the clone to grow more. So
Mhm.
it's a vicious cycle, and she had shown that. But yes, more recently, she's worked on a Mediterranean diet and
Yeah.
shown that how that can be helpful. In the past, when Dr. Robin Sherber used to be at San Antonio, UT, she had worked on yoga. She and Ruben Mesa had done work with yoga. So I think in general, absolutely, if you can quell inflammation, that can only be a good thing in MPNs. But in terms of actual interventions, I think this is all we know.
Mhm.
Mediterranean diet from Angela's work, and then the yoga from Robin's work.
Mhm. And we were hosting yoga classes with one of our staff, Natalie, and they were pretty well attended. We'll have to start doing those again, but yeah, anything you can do, quit smoking, quit
Yeah.
overeating, quit eating sugar. I mean, and that was one of the questions too, Dr. Bose, was, sugar seems to be this major culprit in cancer, period.
Yeah. Yeah.
And so, not getting rid of fruits and vegetables or fruits, that are good for us, but what would you recommend in terms of sugar intake? I mean, where should it be from berries? Should it be from, what are your thoughts?
That is a great question. Unfortunately, I don't think there's a known answer. We certainly all believe that sugar is just generally bad for all cancers. And because, it helps cells proliferate, but I think, what would probably be most useful if patients could get some sort of a guideline, right? Like eat this and not that, or this form of sugar is better than that, and then how much, and portioning like in diabetes. I'm not aware of anything like that, unfortunately, for MPNs.
And it's interesting, and this is true probably in every disease group, that you meet with the specialist, which would be you, but there's really no, there isn't a consensus maybe, or
Yeah.
other people that this patient should meet with to talk about diet, to talk about exercise, to talk about fatigue, and certain things, certain symptoms that MPN patients have. I know the itching and the fatigue and bone pain are just constantly there. We did a study on MPNs, and we sent a survey actually about migraines. And so, what are your thoughts? That was one of the questions also on migraines and MPNs. And this person started using interferon, and the migraines went away, which is ironic because we read all the time that interferon can sometimes cause migraines too. And I want to interject, I apologize. Of all days, they're redoing the roof above us. So if you can hear that, I apologize.
So no, all good points, Anne. And I wanted to quickly throw out, you mentioned smoking in passing earlier. And remember, smoking is a risk factor for clots. I mean, so that's the last thing you want to do,
Absolutely.
when you have an MPN. Now, coming back to the migraines, migraines are more common in ET, at least in my experience. The high platelets, they mess with the blood flow. And so migraines, we often call them microvascular manifestations of ET. It can happen in PV too. The platelets are often, the culprit if they're high. And twice a day aspirin can be very, very helpful. I've found this personally in many patients. There are some papers out there that explain that if you take your baby aspirin twice a day, then you maintain a consistent blockade of the enzymes that produce prostaglandins, etc. So it's just a more logical way of taking the aspirin. I'm not saying everyone should do it if there's no
Mm-hmm.
reason to, but if you have certain microvascular symptoms, so migraines, vision issues, numbness, tingling, these types of symptoms, you could try twice a day baby aspirin, not a full strength baby aspirin. So that is something. Interferon, good to hear that the headaches went away, but yeah, I mean, we don't always think of that as being a likely outcome. Ruxolitinib can cause headaches, So, I mean, again, in my view, migraine type problems are probably best addressed by the twice a day baby aspirin.
Yeah, and so not together, but once in the morning perhaps, and once later in the
Exactly,
day. Yeah,
exactly. Not
yeah.
together.
Yes. And so, and we know, I think we know from last year's research that more women have ET. And in this MPN space, and that was something that we read. And ironically, most of the people that responded to our survey were females, and they were the ones, experiencing the migraines. So we only have 4 more minutes or 5 more minutes here, and I'm so sorry we had to start late, but for the sake of Dr. Bose's time, we will end at noon. And so Dr. Bose, you've done such great work in the MPN community, and we so highly respect you. And could you share with all of us, and this is recorded, so we get so many hits after we're done with these from people that couldn't be with us live, right at this moment. Could you share with us what you see coming in the future, and what MPN patients, let's say, for the newly diagnosed, the young patients, the ones that have had the, disease for a long time, and what do you see happening for all of the MPN patients in this space?
Sure, yeah. To start with PV, because we've been on that topic. I think the biggest thing happening in PV right now is this whole move away from just controlling the blood counts and reducing clots. We're more ambitious now. We're now trying to prevent progression of PV to myelofibrosis and AML. And that is really a paradigm shift that is in progress. It certainly hasn't happened completely yet. But I think the demonstration that ropeg and ruxolitinib can actually lower that allele burden and improve event-free survival is a big deal. So this is something I see the field moving in this direction. Now, about new drugs, all the new drugs right now, or almost all the new drugs right now, are hepcidin modulators, right? So we talked about rusfertide in the beginning, and there are 3 others that are in various stages of development early on, which are similar. Now, similar in the sense that they are not, I should point out, though, that they are not mimetics like rusfertide of hepcidin. Rather, they are hepcidin inducers. So they increase your own hepcidin, okay? But ultimately, it comes back to the same idea, right? That whether by mimicking the action or increasing your own hepcidin, you're really ultimately trying to deprive the marrow of iron so that red cell production is constrained. So that is nice, but it's basically focused on that one aspect, right? Let's control the hematocrit, let's eliminate phlebotomy, which is important, but perhaps not addressing the trajectory of the disease, which in my view is better addressed by ropeg or Pegasus or ruxolitinib. Now, the symptom data, I'll again point that out, because symptoms remain an unmet need, right? Despite ruxolitinib, people have symptoms. Fatigue is a big problem. So if rusfertide can ameliorate that, I think that's going to be very exciting. Now, of course, ET and MF are topics in and of themselves, but maybe just quick one-liners, I guess, in ET. Well, there's less going on because as you realize, it's a less life-threatening disease. Most patients have actually a normal life expectancy. But then there are some drugs being developed in ET. There's a LSD1 inhibitor that Merck is developing. It's called bomedemstat. And there's a BET inhibitor that Incyte is developing. There's pelabresib, which Novartis has, also a BET inhibitor. So these drugs, again, the push in ET is, can we achieve disease modification beyond, just count control and clot reduction? And I would be remiss not to mention ropeg. Ropeg is actually is pretty far advanced in its development for ET and may get approved for ET. They also had encouraging top-line data not that long ago. Finally, MF. So MF, of course, as you know, is huge. I mean, there's that's the major thrust of drug development within MPNs. But again, the idea generally being that we have JAK inhibitors. We know they help spleen, they help symptoms, they improve survival. Ruxolitinib for sure does, and I think maybe the others do too. Ruxolitinib just has the best data. We also have JAK inhibitors now for people with low counts, right? We have momelotinib for anemia. We have pacritinib for very low platelets. So we kind of have that covered. But outside of that, what can we do to, again, extend survival, improve, the kind of the natural history of the disease. And really, at the end of the day, the landmark study showed us this, that what patients are thinking about most is life expectancy and survival. So there is a whole slew, a whole plethora of agents, some of which are better JAK inhibitors, some of which are targeting mutant calreticulin, some of which are non-JAK inhibitors, just trying to partner with JAK inhibitors. So there's a enormous gamut of drugs being explored for MF.
Thank you so much. It just astounds me, having been in this space for 23 years, and I came on the scene when the JAK2 gene mutation was discovered, basically.
Yeah.
And so it's just remarkable to me what the work that's been done by people like you and your colleagues. And it's just been wonderful news for me as an advocate and a person that wants to help patients and make sure that they get their needs met. I can't thank you enough. You always do a wonderful job for us and for our patients. And we hope to see you real soon, maybe at ASCO or in the near future somewhere. But thanks again. We really appreciate it, Dr. Bose. And I apologize to you and everyone for our technical glitches and the noise, if you can hear that. But
I cannot, so I'm good.
Okay, good. That's good to know. But
Thanks for having me.
Have a lovely day, and peace be with everybody. And we'll talk soon. Thank you.
Thank you. Bye-bye, Anne.
Bye.